Hello everyone. Today we are going to talk about what are the things you should know in general examination in CNS. Mainly consciousness. We will evaluate consciousness with GCS and the Glasgow Coma Scale, and cooperateness, obeying commands depend upon the patient ability. For a stroke patient, mostly consciousness is important. Obeying commands and cooperativeness, it's depend upon the type of stroke. And then we have BMI and all, not so important. Then we have vitals. Vitals, you need to understand rate and rhythm. Rate is, if it's high, it means it's tachycardia. It's seen in raised ICT, or like even raised ICT you can see bradycardia also. Then we have rhythm. Rhythm is signifies indirectly irregular rhythm, which signifies the patient is have atrial fibrillation and that can cause embolic stroke. Then we have other things under vessel wall thickening. Maybe if carotid vessel is thickened, means there can be Takayasu arthritis or giant cell arthritis, maybe, but it is not for stroke per se. It's not. For vasculitis side, stroke can occur. So vasculitis can cause stroke, but for vessel wall thickening can be due to that. Then we have carotid and vertebral bereavement, that there is atheroma there, some blockage is there which causing turbulence of blood flow. You can hear with the stethoscope. So then we have blood pressure. Blood pressure is maybe if it is high in hemorrhagic stroke, and thrombotic stroke, it's vary, because hemorrhagic stroke patients will have a high BP, and not chronic in a way, sudden high BP, and thrombotic stroke patient will have a high BP which is a chronic hypertension patients. Then you have respiratory rate. The respiratory rate, why the male patient will have a abdominothoracic respiration and females have thoraco-abdominal. The thing is, for male, the abdomen muscles which are very well developed and they have very bulk and mass, so they formulate the respiration in males because they have a well developed muscles. But in a female, the abdomen muscles are little bit weak and they have a less muscle mass, so their respiration is stable because of thoracic. Because thoracic region for a female, it's very heavy because of the breast is there, so they have a muscle which is very highly muscular in the thoracic cavity, so they have a thoraco-abdominal respiration. Any use of accessory muscle per se in CNS, the use of accessory muscle is not so important. Then we have general examination in nervous system examination. Then you can see pallor, icterus, cyanosis, clubbing, lymphadenopathy, epididyma. JVP and all not so important in CNS case, and maybe pallor can be associated with vitamin B12 deficiency. Icterus can be seen. Icterus and all like not actually related to CNS. They won't ask you like those things. Cyanosis is also not so related. Clubbing also not so related. Lymphadenopathy can be there because a lot of people have Hodgkin's lymphoma. They can metastasize to the brain. Edema and all not completely related to CNS. One thing is pallor or icterus may be related to CNS. Then we have signs of nutritional deficiency, external marker arthroscope. They won't ask you this. Neurokeratinase markers they can ask. I will explain those neurokeratinase marker in a separate class. Then we have nervous system examiner. First you have to understand right hand person or left hand person. Then we have to assess the education quality, because depend upon the education thing, you have to assess the higher mental function, because you cannot ask complex questions in uneducated people. So you have to educated people. You have to your question will be different. For example, in memory you can ask numbers, okay ma'am, but for uneducated people we will ask them to count notes. For example, money is a thing the everyone knows. So for educated people, you use numbers and subtraction, addition. The same thing will happen in an uneducated person. They have to ask the patient to count the money. For example, 100 rupees, 300 rupees, those things everybody knows, okay ma'am. Then we have first you have to start with consciousness, orientation. In orientation, you have to understand the first thing it will be lost is time. Even though if you're going to a bus, you become tired, you went to your hostel, you got start sleeping now, you will understand when you wake up, you don't understand like you don't know what time is. So time is the first thing to lose. Then we have place. Then you have person. The person is the last thing to lose, because the patient is that much disoriented, he don't know who he is. That is the sequence of disorientation. Then we have memory. We have immediate, recent, remote. Remote means the patient can the past events. Recent means like up to 5 minutes. For example, or 5 minutes back you had some question, if you ask the person they can recall. Then immediate memory, for example 30 minutes, for example you ask the patient to remember two things and ask after 30 seconds. This is immediate memory. And intelligence, mood and emotions are like these things are actually you can assess consciousness, orientation, memory. Intelligence are you don't need to ask. Concentration and calculation and all like not much needed. Speech is very important, because people most of the examiner will ask you how speech is exactly processed in a person, because speech is very important, because speech has different pathways, because it will say different pathology. For example, speech has aphasia, dysarthria, dysphonia. You need to understand if this patient is having aphasia means which part of the brain is affected. If the patient has aphonia means which part of the brain is affected. That means dysphonia. Dysarthria means which part is affected. Look, dysphonia means difficulty in production of sound. That means the patient is having laryngeal problem. Something is in the larynx is problem. Then he has aphasia. Aphasia is a cortical defect in the speech. If dysarthria means articulation. You will speak some words. They have each and every words have a different type of articulation. For example, if you're saying A, E, F, O, so these words have different kinds of articulation in your oropharynx and your hypopharynx and your laryngeal cavity and your oral cavity, your tongue. Everything will contribute to each and every different words, because that's why words are produced. So if the patient having problem in cranial nerves, it causes dysarthria. The thing you can understand is in dysarthria can be occur in facial nerve palsy. In that, because facial nerve, your glossopharyngeal nerve and your cerebellum, these can cause your dysarthria. Speech is a separate topic. If you want to know about speech, I will take a separate class, because it will be a short class. I can explain in detail there. And hemi-neglect and apraxia, they are very higher mental function. You don't need to actually mention patient have apraxia, hemi-neglect, hallucination. You are just have to mention higher mental function: consciousness, orientation, intelligence, speech. These four things are more important. If you mention these four things, your higher mental functions are done. Then we have cranial nerves. Like I would say, most of the things in cranial nerves are not so important. You know how to examine olfactory nerve, optic nerve. If all extraocular movements are normal, then those three nerves, 3, 4, 6 are normal. Then you have trigeminal nerve. The sensation is normal, jaw jerk is present, and you have the corneal reflexes. There means if your fifth nerve is normal, you have to think the main nerve is facial nerve. Facial nerve is the one of the main nerve, because why facial nerve is main nerve is because it's most commonly affected in stroke. So you have to study facial nerve examination from top to bottom. First thing you have to understand, if facial nerve is gone, your facial symmetry is gone. So if the patient is having facial asymmetry, that means facial nerve is involved. That people will have angle of deviation of mouth toward the normal side. Okay, wow. Then we have first you have to see the symmetry, then you have to see the motor function. Frontalis, ask the patient to raise the elbow with resistance. If the patient is raising the elbow, you have to push the eyebrow down. So you have to check the power also. This is how you have to check the power. Then orbicular saga, ask the patient to forcefully contract the eye. You have to retract the eye. You're giving resistance, patient is doing. If the patient is not able to do, that is weakness is there. Buccinator, that means blowing of cheek, whistling. Orbicularis RE and platysma, like pull down the corner of the mouth. So these things are affected means there is some sort of but mostly your upper muscle, like your frontalis and your orbicularis oculi will be spared in most of the stroke. That means upper motor lesion of facial nerve palsy, because your upper half of the face is spared, because your half of the face is supplied by bilateral nuclei. I will clearly explain facial nerve palsy in a separate video, because with motor I will explain. Just understand, this is how you have to examine sensory anterior two-third of neck. You are going to examine taste. Other than this vestibular cochlear nerve, just understand, okay, Rennie's test, Weber test I will do, glossopharyngeal nerve I will do gag test, because these nerves are like very few conditions. These are like postgraduate level. These nerves, hypoglossal nerve, sensory, spinal accessory nerve, these are affected in higher of diseases. For a normal stroke, for a UG level, just understanding how to examine facial nerve is more than enough. Then we have motor system. Motor system then is the most important part in CNS examination. First you have to see the attitude of the limb. How was the attitude, whether it is attitude means where it is lying. For example, if it is in the flexion position or in extended position, or it is in the pronated position, because each and everything, every disease will have a different kind of attitude. Then you have to see the bulk. You have to see arm 10 centimeter from the above olecranon and 10 centimeter below the olecranon. 10 centimeters to measure the centimeter. If there is two disparity between two arms, there is bulk is low. Then you have thigh also 18 centimeter from the superior border of patella and 10 centimeter below the tibial tuberosity. Then you have to assess tone. Tone is you can assess by ask the patient to flex and extend. You have to see whether the patient have a higher tone. You have to compare both things. For example, you are doing a flexion in the forearm. So if it is very resistance mean it is hypertonia. If it is very flaccid, you can able to easily move the limb means that is hypotonia. Then we have power. Power is most likely it has a grading. You have to understand what is power. There is a separate definition of that. I will entirely tell you like how power is assessed in like motor examination. I will next video will be I will cover speech, power and facial nerve examination, the three important things. Here I am giving a general idea of what are the things you need to know in CNS examination. Power from 0 to 5 you have to say, okay ma'am. Then we have you don't need to assess each and every muscle power. You have to just say for in forearm flexion extension muscles are normal, in wrist flexion extension normal. This is how you have to say. Don't say each and every muscle you don't need to see. And then we have reflexes. We have deep superficial reflexes, deep reflex. Superficial corneal, conjunctival, and we have the abdominal reflexes. In this mostly you don't need to assess the abdominal reflex, cremastic reflex, anal reflex, and these three reflex: corneal, conjunctival, jaw jerk, and cremastic and anal reflex. But jaw jerk will come under deep tendon reflex. Then we have jaw jerk, biceps reflex, triceps reflex, supinator reflex, and we have ankle reflex, knee jerk. So this is done, and we used to see even patellar reflex also sometimes. Then we have this primitive reflex. Just you need to know what is this primitive reflex and all. So next is sensory. Sensory means touch, pain, temperature. Look, there are two things. One is primary sensation and cortical sensation. Cortical sensations are very fine sensations. For example, tactile localization, 2-point discrimination. If these are lost, means your posterior column of the spinal cord is lost. So like mostly sensory system is per se is a function of to assess the spinal cord. Then you have cerebellum, outstretched handstand, finger to finger, finger to nose test. This, if you know these names, okay ma'am. In stroke patient, if the patient having stroke on right side or left side, that side of the hand he or she can't able to do the cerebellar test, because you have to mention in the case sheet patient is not able to I am not able to assess because of weakness is present on this side. That side cerebellar signs are normal. For example, right side is stroke, left side is normal. This is how you have to mention in the case sheet. The reflex and all, you have to say jaw jerk is present, ankle jerk is present. Anywhere in your case sheet, please don't write I am not able to assess, because motor examination you have to assess, sensory you have to assess. Even though if you didn't assess the case, just you have to write sensory system is normal, pain, touch, temperature intact, and the same thing reflex is intact in normal side. In abnormal side is exaggerated. For example, there is will be hypertonia, the UMN elimination. I will explain UMN elimination in the motor system separate video. Then we have gait and all, mostly for a stroke patient it can be circumduction gait, whether it is a hemiplegia. Then the autonomic system, just mention there is no sign suggestive of autonomic system involvement, and no signs of meningeal irritation. For example, Bridenski Rennick sign and neck stiffness is not present. Other than that, other system you have to just say RS system, normal vesicular bed sound is present, no added sound. Then we have CVS, S1, S2, no murmur. Gastrointestinal system, abdomen is soft, non-distended, no tenderness present, bowel sound is present. This is how you have to write the entire examination part of CNS. Okay. So next video we will see cranial nerve examination in facial nerve per se, and we have motor examination. In that I will explain how will you check Babinski sign, and the plantar reflexes. If you're not able to elicit plantar reflexes in the foot, we have to go with hand, those things. And primitive reflexes, why you need to know. Those are the some primitive reflexes, glabellar tap and rooting and sucking reflex. We will see that, and then we'll see a separate video for speech. Okay, bye.